everyone. I'm Dr. Jeff Rohde. Welcome back to the live Dentalcompare webinar series. Today we have an amazing program for you covering the epidemic of sleep apnea. We're here with Dr. Michael Gelb, and if you haven't heard him talk before, he's awesome, and he is pretty much one of the main authorities on the topic, so you're in for a treat. And that's the thing. As dentists, we are perfectly positioned to be able to help the growing number of patients suffering from sleep apnea. The whole program will last about 45 to 50 minutes, after which he'll respond to your questions to round out the hour here. You'll have the opportunity to ask questions at any time during the presentation using the question box right there on your screen. Just go ahead and type it right in. That includes any technical issues. If you have any sound issues or anything, we have someone who can help you with that as well. If we happen to run out of time before your questions are answered, we do keep track of all the questions submitted, and we'll be happy to provide a follow-up response. So we will get to everything. One more thing, too. If you'd like to watch this again in less than 24 hours from now on Dentalcompare, this will appear as an archived version. So please tell a colleague about it or show it to your staff. The entire program will be available to watch. So again, I'd like to welcome Dr. Michael Gelb. He is an innovator in sleep apnea, painful TMJ disorders, and other head and neck pain conditions. Dr. Gelb has studied breathing-related sleep disorders, specializing in how they relate to fatigue, focus and pain, and the effects of all these that they can have on a person's life. He received his DDS degree from Columbia University School of Dental and Oral Surgery in 1982 and his master's degree from SUNY Buffalo School of Dental Medicine. So, Dr. Michael Gelb, welcome to the presentation.
Thanks, Jeff, and it's a pleasure to be here, and it's always, I'm passionate always to speak about the role that dentists can play in the treatment of sleep apnea and some of the new concepts that we have in how to integrate sleep into your dental practice. So if I can, we have a slide up now that talks about Airway Centric. And Airway Centric is a term that I have developed, and it kind of is just a different way of looking at the field of dentistry. Airway Centric is really it's a brand, and it is a dentists have always looked at as dentistry as being about the teeth. And one thing you'll hear me say today is that if you want to talk about teeth and you want to do work on people's teeth, you really shouldn't mention the teeth. I believe that the reason that we have teeth is to support the airway. One of the things you see here just in this opening slide, we talk about airway restorative dentistry. I believe that the airway is the top of the hierarchy. It's the top of the food chain. It trumps everything else. And below the airway, we talk about TMJ, we talk about muscles, we talk about the joint, and then the last thing we talk about is teeth. You know, I say if you look at this slide and you look at the colored section that's in, magenta, or you look at pink, that is the airway. And, as we go to this next slide, you can see that as dentists, we are probably the best people to treat the airway because 90% of the obstruction that we see is behind the maxilla, behind the upper jaw, that is the soft palate, and behind the lower jaw, and that would be the tongue. So if 90% of the obstruction is in that area, we work closely with our ENT colleagues because you really need to be able to breathe through your nose in order to have an open airway, because if you have nasal resistance, things are going to shut down much quicker behind the palate and behind the lower jaw. So pulmonologists have historically been very involved with the treatment of sleep apnea. They've used CPAP. But it's really the dentist that is addressing and that spends every day of their career working with the maxilla and working with the mandible. So I think we as a dental profession, we're probably in as good as any other profession, and probably the best profession to be the ones that are addressing everything from snoring to mouth breathing. We're going to talk a little bit later about mouth breathing, and we're going to talk about upper airway resistance syndrome. So I've been looking for the past 28 years, I've been looking at, certainly starting my career looking at TMJ, orofacial pain, looking at condyle position, looking at disc, and really not really being interested in sleep at all. In the 70s, in the 80s, and 90s, we did a lot of work, and we saw a lot of talk about performance. And then in the 90s, the 2000s, there's been much more work done on the airway. So there's basically three areas that we look at in our practice, and part of what we look at is the mouthwear. We've been making appliances for a long time, and the first part would be Gel B. That would be what I call a bite, balance, and breathing system, and we talk about performance mouthwear. And the research is not really in on concussions yet, but it's hypothesized that if you can dampen, if you can prevent the force from being transmitted through the lower jaw, if that's where you happen to be hit, then you can dampen the blow and maybe lessen concussions. We know from the literature that we're quite effective in terms of using oral appliances to treat snoring, sleep apnea, and restless sleep. And then lastly, headache, clenching, and TMJ. Now, what you see there, if you look at the stitched together cone beam, I think dentistry has an obligation to look at not only the soft tissue profile, certainly to look at the mandible, look at the maxilla, look at the hard tissue. Certainly we've been taught to look at the teeth. But we also analyze the neck. We look at the cervical spine on every patient. We look at the airway on every patient. We analyze the TM joint. We analyze all the muscles of the head and neck. And we do that on every patient that comes in. You know, once we do that, if we don't ask the right questions, which we're going to talk about later, we're not going to get the right answers. So this is a little bit of the history. You know, I went to Tufts undergrad. My dad went to Tufts Dental School, and I came back and I went to Columbia Dental School, and I've been teaching at NYU since 1989, where I ran the TMJ and Orofacial Pain Center. And we've been looking at the evolution of the jaws, and we've been hearing this word epigenetics from people like Dave Singh and Kevin Boyd, who's doing his PhD on this out in Chicago. Epigenetics relates to the effect of the environment on the phenotypic expression of the genes. So we've seen rapid changes in the presentation, the growth, and the development of the maxilla, the mandible. And what we've been seeing, which we're going to talk about a little later, is basically a stunting of the growth of the maxilla and the mandible. So we'll talk a little bit later about the history of dentistry and orthodontics. We'll talk about centric relation. We'll explain a little bit about GELB 4-7. My dad is still alive. He just stopped practicing this year, and I'm still practicing here in New York City, as well as teaching at NYU. So the primitive jaw is the well-expanded maxilla that we see on the left. So all 16 teeth, at least 38 millimeters between the molars, and this is really what we used to see. Now, Michael Nuri is my patient. He's got a primitive type jaw, but most of the patients, I don't know where you live or what you see, but I've got to believe that it's the same that we see in Manhattan, is that very few of my patients come in with a upper jaw that looks like that. The majority of my patients, when they're kids, they have a narrow maxilla. They have maybe 25 or 30 millimeters between the first molars. They don't have the 38. They have a narrow maxilla. It's a constricted maxilla. And basically, because this is the base of the nose, if you have a narrow maxilla, excuse me. Let's see, Cindy. Sorry about that. Give me 1 second. Okay, I'm back. So basically what we see is this is where the maxilla should be. If you see the dotted line, 82 to 85% of all maxillas today are retruded. So when we treat, so we call this a bimaxillary retrusion. Most of us have upper jaws and lower jaws that are retruded. And that has a huge impact because snoring and sleep apnea is primarily an anatomical science. So if you look at this upper jaw, the upper maxilla, that is the U shape. That's more of an ideal shape. That would be a finished arch. But we can't just look at the shape of the bone. We have to look at where's the position of the teeth in the entire cranial facial skeleton. Where is the maxilla? How far out are the centrals? And Kevin Boyd talks about this end perpendicular, and in most of the cases now the maxilla is retruded from that plumb line that's dropped down. This is typically what we see, a V-shaped maxilla. And of course, if you have a maxilla like this, the mandible is going to be retruded and the tongue will be retruded. Very often these patients have a well-expanded or a better expanded mandible associated with a maxilla that looks like this. And this is pretty much the norm, not the exception. Again, a constricted maxilla on the left, and even this expanded maxilla on the right is still way too narrow. Now, we talk a little bit about frenectomies. When I talk to the pediatric ENTs that we're talking to at NYU, you know, we're talking about this thing which should have been snipped at birth. And it's very easy for the ENT to go in there and to take care of this lingual freedom. Today in dentistry, we have lasers. BioLase has an Epic laser, and that not only can be used to treat the TMJ as a cold laser, not only can it be used to treat aphthous ulcers and lesions and used for a variety, but it also can be used for frenectomies. This is something that if you do not release a lingual frenum, you will most of the time not get development of the maxilla. So if we looked at that previous slides, and we could see that the tongue, presumably, not only could this child probably not breastfeed, be almost impossible to breastfeed with this type of tight lingual frenum, but you would not get the development of the maxilla. So it's essential today that all pediatricians, pediatric dentists, TMJ practitioner, sleep practitioner recognize not only a tight lingual frenum, but the labial frenums on the maxilla as well. What we see and what we try to explain to the ENTs and to the parents is that if you have a narrow maxilla, you're going to have diminished nasal airway. So in other words, if you have a narrow maxilla like in B on the slide, because the ceiling of the palate is the floor of the nose and converse, this triangle is not going to be, even if you have septoplasties, even if you have turbinectomies, you're still dealing with a way diminished airway. If you look up above an A, when you have an expanded maxilla, you have the potential, the full potential to be able to breathe through your nose. So I can't tell you how many patients I see with narrow maxillas, and a lot of these patients have had 2 bicuspid extractions on the maxilla. So I think that, you know, not to condemn the orthodontic profession, but any of those cases where there is a retractive headgear or there is any type of extraction in the maxilla, it most likely resulted in a diminished nasal airway and certainly diminished space for the tongue. When you diminish the airway and you make this space less, where's the tongue going to go? Most of the time it's going to go back in the airway. I think we need to be aware that when we see a mouth breather, this is Napoleon Dynamite on the right, and that might be your child on the left, this is a sign of sleep-disordered breathing. And I mean, I've been doing this for a long time. I just realized that my mouth breathing, I mean, I don't know what took me so long for it to hit home, but I realized that my mouth breathing is because I can't breathe through my nose. Now, that might sound obvious to you, but most people think that this girl is very cute. And I think that most dentists don't realize that mouth breathing is pathologic. And it can lead to growth and development problems. It can lead to the change in the shape of the face. And it is a sign of sleep-disordered breathing and needs to be intercepted at a very young age. Now, I believe that we are becoming bulldogs. And I believe that this is basically the shape that our face is going. If you look at the snout, this dog has what we call a brachycephalic syndrome. So this has the tissue, the snout, the maxilla, if you will, is smashed in. The patient cannot, this dog cannot breathe through his nose. He's got an elongated soft palate. If you notice, he's a mouth breather. See how his tongue is hanging out of his mouth? There's no place for the tongue to go. Well, if it goes into the back of the throat, he would choke and he would die. Dry nose, pinched nostrils, tongue and palate is compressed, abnormal number of teeth, probably crooked teeth, congenital heart disease, and a short face. This is what we see when we look at the cone beam CAT scan. When we have a face like that, when we have a retruded maxilla, when we have a maxilla that's too far back, if we look at this red arrow here on this slide, we look at the distance between the soft palate and the back of the throat. This is diminished. When we look at the axial view, which is on the bottom left, there's basically no airway. This is during the day. This is with the patient upright. Every patient we look at gets an ENT evaluation. So their septum is examined, and it's examined through the full length of the nose, and this is very easy to do with a Newtome VGI. It's super easy to scan from the tip, and every one of my patients gets a sagittal view, coronal view, axial view, and we take them through the full extent of the view. Every one of my scans is read by a board-certified radiologist, Christos here in New York, and he gives me a evaluation. He gives me a reading and a signature on every case that I read. So you see here that when the upper jaw is back and when the lower jaw is retruded, we certainly can get a diminished airway. So if we're not evaluating that and we're treating teeth and we haven't identified the airway, we're doing a disservice to our patient. Let's say the patient gets diagnosed. You've just done a 3-unit bridge, a 4-unit bridge. You've done a maxillary arch, mandibular arch. The patient gets now treated with CPAP or gets treated now with an oral appliance. Their bite changes, and now their bite doesn't fit. Well, the question that the patient would ask you, well, is there any reason why you didn't diagnose my airway issue before you did the dentistry? Now my bite is off and my bite doesn't fit. Something to give thought to. Now, if you look at this lady here, this is my patient. She's a lovely lady, and I'd say if you look at the picture on the left, this lady has basically one foot in the grave. She does not look well. If you look at her on the right, that's about 3 months later. What you see, and this is the potential that dentistry has, we can transform people's lives. This lady on the right has a look in her eye. She has life. Her skin has changed. What's this all about? It's just a matter of increasing vertical dimension? I don't think so. In the old days, a lot of doctors, and as recently I lectured to the full mouth rehab course at NYU and Dr. Vafiatis, and Dr. Vafiatis said, he said, I used to think that people came back after I did a full mouth rehabilitation and they said, you know what, doc, I feel so much better. And he would open up the vertical, and he thought it was because they looked better and their self-esteem was better. He said, Michael, after I took your course, I realized, and this is true if you increase vertical, if you have a denture patient just keep their dentures in at night, they are going to sleep better. They're going to get a deeper night's sleep. They're going to get more stage 3 sleep. They're going to get better REM sleep. And so when you look at the before and after of this patient, and this is something, look, when I went to Columbia, they told me I couldn't change vertical dimension. We now know that's not true. What we're doing when we transform this lady, and it's a lifetime transformation, we are not only increasing the oxygen saturation in her bloodstream for most of the night, we are allowing her to have less inflammation, less oxidative stress. Her endothelial dysfunction is normalizing. We're reversing heart disease, if you will. She's getting more blood flow to her brain, to her extremities, to her heart. And so if you look at her eyes, if you look at the color of her eyes, if you look at her pupils, if you look at her skin tone, this is a different woman, and this took about 3 months. Now, so if anyone talks about dentistry, aesthetic, this is a much higher way of practicing. And the airway is what it's about. It's not about the TMJ per se, although the TMJ can have very powerful effects on many of these people. This is an effect that we just can't take for granted. But this is something that every dentist can do, and really the dentist may be the best type of professional to do this treatment. I can't say enough about this slide. This slide, and if you look at this lady from a lateral point of view, what you end up doing, if you see the patient on the right, is you've changed her head posture. You've gone from a woman who had decreased vertical, she had a closed airway, and she had to put her head into extension with a forward head posture in order to breathe. The woman on the right is alive. Her eyes are open. Her head, her ear is above her shoulder, and she can hold her head upright. And that's a result of everything that we've learned from the years. I certainly learned a lot from my dad. And this is what someone can look like with allowing them to breathe at night and not allowing their airway to close. We've got to realize that in dentistry, we've been closing airways for about 75 years. Now, this is Uga the Bulldog. So the Bulldog on the left is the Georgia Bulldog, Uga, from 1956 to 1966. And if you look at the evolution of the Bulldog, it really parallels what's happened to the human condition. When I was graduating dental school in 1982, the obesity rates in the United States were between 8% and 10%. Over a period of time, the obesity rates now are above 25% in many states, up to 40%. So if this is the Bulldog, and there's been a lot of outrage in the American Kennel Club, we are breeding this dog into extinction, much the way we may be breeding our society into extinction. If we look at the rate of obesity, there's a trickle-down rate, obviously, to heart disease, sleep apnea, diabetes, and there are many epidemics in this country that we see. Now, cone beam is a good way. If you look at the modern Bulldog, the fat Bulldog, and then you look at the ideal Bulldog, you can see that the airway is greatly opened up in the ideal Bulldog. And so but don't let me lead you astray. You don't have to have obesity. You don't have to be overweight in order to show signs of snoring and sleep apnea. Now, this is my patient. My patient is the modern Bulldog. He looks exactly like the Bulldog. His maxilla is retruded. He's lost vertical dimension. He doesn't have any lips. His mandible is retruded. If you look at the retropalatal area, retroglossal, this patient, if you look at the red line, has a retruded airway, has a diminished airway, collapsed airway. So he's got a thick neck. In men, this will be above 17 inches. He snores. He's got a collapsed airway. He's got a malaligned jaw, elongated soft palate, and he's got sleep apnea, which has led to heart disease. This is the modern Bulldog, and they're all over. Probably 30 to 40% of our practice. Certainly 20% of our practices have obstructive sleep apnea. So when I show you a young boy like this who has a retruded mandible, are we going to promote horizontal growth, or, as in so many cases, are we going to bring back the maxilla? Are we going to take out two bicuspids on the maxilla and just bring that back and collapse the airway and do a flat profile? Or are we going to promote the type of orthodontics, which I think is very rare, where we advance the mandible and promote horizontal growth? And there's been a lot of controversy with growing mandibles and does it work? So I ask all of you out there, is this guy going to be a future snorer? And how are we going to look at this case? Are we taking cone beam? CAT scan. Cone beam CAT scan is now the standard of practice, because if you can't see an airway, and I'm not talking about a cephalometric X-ray, I'm talking about a three-dimensional cone beam CAT scan, a full view, full head, full view, get the TMJ on every image, get the airway on every image, and try to X-ray even down to C3, C4, and get a full image. Because if you get an image and if you don't have the TMJ and you don't have the airway, I don't think you're practicing. I don't see how you can practice orthodontics. It makes no sense to me. So if this is the future of our country, because of what I'm going to tell you in a few minutes, if you're not treating this kid to an open airway, you are not practicing the standard of care. What are some of the anatomic risk factors? And I say, what are the anatomical risk factors for sleep-disordered breathing? And I take this from an article called Death and the Nasomaxillary Complex and Sleep in Young Children, European Journal of Pediatrics, 2012. When they did an autopsy of kids that had died within 2 to 3 years of age, they found that these kids all had high and narrow hard palates. They had retruded mandibles, they had enlarged tonsils, they had enlarged adenoids, they had deviated septums, they had small upper airways, and they had insufficiency of the bony nasomaxillary complex. Now, these are not kids that are born with craniofacial anomalies. These are not kids that have syndromes. These are regular kids like you and I would have. They could be on the spectrum. They're not. They're normal kids. And these are kids that died, and these are the risk factors. These are the most serious risk factors that would be involved with death. Most of the time we're not talking about death. We're just talking about chronic disease and poor performance. Some of the other risk factors that we see when we look at children would be big tongues. In dentistry, the only time we're cursing the tongue is when we're working on a lower second molar, lower first molar. Our assistant has to help us. We're working on the lingual. We're prepping for a crown, and that tongue is the tongue is in the way. We look for tight frenums. We look for tight lingual frenums. We have to start looking at nasal anatomy, either through cone beam CAT scan or doing a nasal examination or working with our ENT colleagues. We look at craniofacial anomalies, small maxillas, small mandibles, narrow maxillas. High Mallampati, we do a Mallampati score in our patients. Allergies and things like certainly obesity increases the risk. Patients with a long face tend to have maxillas that have grown down and back, tend to have higher incidence of excessive daytime sleepiness and sleep-disordered breathing. I mentioned 38 millimeters before, but a maxillary transverse deficiency, retrognathia, and aberrant facial development. Now, a lot of you will look at these kids and they'll say, wow, isn't that a sweet-looking kid? But that kid who's a mouth breather, that is a sign of sleep-disordered breathing. And if you look at Karen Bonnick's work, mouth breathing and snoring have been associated with increased rates of neurobehavioral problems like ADHD, aggressive behavior, anxiety, depression, hyperactivity, inability to get along with peer groups. And this is serious stuff. These are kids, and if you look at that little girl that's sleeping on the right, she's going to develop a long face. You can see she's got a short upper lip. Her mandible is going to be retruded, and she's not going to get an acceptable orthodontic result, and she's not going to be a healthy kid. She's not going to be a healthy adult. Now, what we see a lot of times, we know that kids don't get enough sleep, but this kid is either going to be bouncing off the walls, or when she's in high school, she's going to be falling asleep on her book like this young lady. Let's just talk about sleep stages for a second. You know, when we're a kid, when we're a baby, so probably the most important period of our life is 0 to 5 years of age. This is when the brain is doing most of its development, and we're advocating for orthodontics to get involved between 3 and 5 years of age because that's a critical period of brain development so our kids can read and they can learn and they can get proper ideal brain development. If we look at sleep stages, there's approximately 5 cycles throughout the night. And you know from being with a healthy kid that kids can sleep through anything. They spend a lot of time in what we call stage 3 and 4. Now it's stage 3. But delta sleep, they spend a lot of time in this deep sleep. We know as we get older, we don't spend as much time, but you can see that most of the time we go from wakefulness and we go through a period of stage 1 sleep, then stage 2, then stage 3, and stage 4, and then we come back up. We have some REM, and we go through, most of our REM occurs later in the night. We go from short stage of REM initially, and as I said, most of the REM occurs later in the night. We get some of our deep sleep earlier in the night, and we go through these 4 or 5 cycles where we come down into deep sleep, we come up, and we come down again, and we come up, and we come down. And so we should get a certain percentage of our night has to be in this restful restorative sleep, approximately 20 to 22%. REM sleep, which is our rapid eye movement sleep, is very important for consolidating our learning and our memory. So if we don't get the sleep, we're irritable, we're a little cantankerous, we might be aggressive, we don't feel well the next day. It's very important that we look and we analyze the sleep stages and we make sure that we get enough of this good sleep. So in the Journal of Craniomandibular Function, they looked at kids and they said, these are some of the symptoms that we see at night and these are some of the symptoms that we see during the day. So at night, mouth breathing. Now, most parents will say, "Oh, there's nothing wrong with my kid. He's mouth breathing. It's normal." And the pediatrician will say, "Yeah, just observe it. Just watch it." Mouth breathing is not normal. Snoring is not normal. And we saw about 27% of kids snore. Snoring is a sleep-disordered breathing problem. Snoring is not normal. Witnessed pauses, one witnessed pause, one apneic event over the entire night is symptomatic and is indicative of sleep apnea. Restless sleep. A kid that sleeps in your bed that kicks you, a kid that is turning in bed is restless, that is not normal sleep. Frequent awakenings. We see things called parasomnias. Parasomnias would be sleep bruxism, periodic leg movement, sleepwalking, night terrors. Patient wakes up confused. Then we see things like nocturnal migraine, drooling, and our abnormal sleep posture in an attempt to maintain an open airway. Now, what do you see during the day? So that's what you saw at night. What do these kids look like during the day? Well, we always learned that if you had a morning headache, it was probably from the fact that you were clenching at night. Not always so. Morning headache is a sign of a breathing-related sleep disorder. We see during the day, we see mouth breathing. The kids they can't breathe through their nose, so they have lip-open posture. They're a mouth breather. Thirst, excessive thirst. You've been breathing through your mouth all night. You're dry. Excessive daytime sleeping is probably the number 2 or 3 complaint of all my patients that come in as adults. I am exhausted. First, all the TMJ patients have excessive daytime sleepiness because they're bruxing at night. And every time they brux, their brain is waking up. But most all of the sleep patients have excessive daytime sleepiness. So basically, I don't know about your practice, but in New York City, excessive daytime sleepiness and fatigue is probably my second or third complaint. Some of these kids are shy or withdrawn. Now, if you look at, unfortunately, what happened in Newtown, if you look at Aurora, these kids they're withdrawn. They're outcasts, some of them. And I'm not saying it's a mental illness problem, but a shy kid, a withdrawn kid, the kids can show things like they can show aggressive behavior. They might show signs of ADHD. Some of these children are irritable. They don't get along with their peer group very well. They might be depressed. Some of them have a difficult time concentrating. They're inattentive. They have learning difficulties. Some of them have memory impairment, and they can have poor academic performance, which could either be a result of their behavior, it could be neurobehavioral, or it could be neurocognitive. And Gonzalez looked at this in rats. Now, sleep-disordered breathing. According to Bonnick, some of these neurological effects may be irreversible if we don't catch them during the critical phase. So sleep-disordered breathing peaks between 2 and 8. There's no coincidence that tonsils and adenoids, this is their peak period of hypertrophy. That's 2 to 8. We know that breastfeeding confers an advantage. So we know that there's a immunological effect. There's a shrinkage of the adenoids and tonsils as a result of breastfeeding, which is important to remember. 2 to 8 is a critical period of brain development. So that if we don't intervene both with adenotonsillectomy and with palatal expansion at an early age, and I'm talking about preferably before age 5 and 6, I want to get these kids mainstreamed by the time they get to kindergarten. And we know that 10 to 21% of our kids are snoring between 6 months and 81 months of age. Symptoms were seen to peak at 30 months of age. So we already know at 6 months and 18 months and 30 months who's going to develop ADHD, who's going to be withdrawn, aggressive, anxious, depressed. And we see a 40 to 100% increase in neurobehavioral morbidity at age 7. That's from kids that have sleep-disordered breathing between, let's say, 6 months and 81 months. This is compelling. Now, for those kids that have sleep-disordered breathing, obstructive sleep apnea, which is mouth breathing, snoring, apnea, those kids have behavioral difficulties. At age 4, there's a 20 to 60% increase in behavioral difficulties. At age 7, as we said, there's a 40 to 100% increase. And there's a 200% increase in hyperactivity. So we see in these children behavioral difficulties, inattentiveness, hyperactivity, anxiety, depression, peer problems, conduct issues, aggressiveness, rule breaking, and impaired executive function. And we see it early. Now the good news is it's probably preventable. Now when we talk about ADHD, learning disabilities, and special ed, if a child has ADHD, then there's an 8 times increased incidence of learning disability. There's an 8 times increased incidence of anxiety, and there's a 3 times increased incidence of low social competence. 40 to 80% of the 3 million kids in special ed also have developmental disability also have ADHD. So we're talking about a problem that is costly. It's costly in more ways than economic. It affects the family and affects the future of our country. Fortunately, breastfeeding from 2 months to 5 months protects against sleep-disordered breathing. Is it all we need to do? No. Does adenoid tonsillectomy help? Yes. Does palatal expansion help? Yes. But breastfeeding is something that we should be promoting as a profession. Well, what's the first-line treatment for these children? Well, obviously tonsillectomy. And by the way, if we're not looking at the tonsils in all of our patients, we're doing a major disservice. And I was talking to Bill Lieberman at NYU. He's now looking at every case. He's a pediatric dentist. Every case now he's evaluating for tonsils. Look at the maxilla. I mean, rapid maxillary expansion is a terrific tool. And you could start it early, 3 years of age, 4 years of age, 5 years of age. Now, this is what I see in my practice on the left. I'm seeing these patients as adults. I don't always get them as kids. I'll treat them as kids. I mean, I don't treat kids pretty much younger than age 7 or 8. I try to get them to the orthodontist. But if I need to get rid of their headaches or their neck aches first, I'll do that. But we're trying to see, obviously this is not inevitable. And what's the price? What is this patient on the left? How hard does he have to work? What's happening with his autonomic nervous system? How hard? What's the price of him having to work to breathe so hard? You know, centric relation, when we look at that, and I was born into a family where I remember the centric relation wars, and you have to go back to Stewart and Stallard and B.B. McCollum and Thomas and Dawson, and you know, we've been in a retrusive field. We've been in a field that's been closing airways for about 75 years. And I think it's time for dentistry, if you look at the evolution of the field, and here's a history from Bonwell to Angle. And basically when we went from Angle and then we went to Tweed, and Tweed promoted 4 bicuspid extractions, it was a way of making a case more stable. I think we really, you know, we took a turn there, and I think we know better than that now. And this is the age of looking in dentistry, looking at airway-centric, and having airway-centric being a way of thinking in dentistry, so that when we get a girl like this, she comes in, she's a 20-year-old female, she comes in with clicking, she comes in with popping, and I look at her, and I look at the 4 bicuspid extraction, and I look at the narrow. Now, this is a result that we get in New York City area. This is kind of a, I'm not going to say it's a typical result, but it's not an atypical result. This is who walks into my practice. This is our orthodontic result in New York City. We look at the girl, and she's got a big neck, and we take a cone beam CAT scan with our Newtome VG. And how do I practice without this? You know, my father's one of the biggest advocates now of cone beam, because we can actually see what's going on, and we can look at the patient's soft palate, their tongue. We can look at their airway. Now, this girl comes into me with the chief complaints of right jaw locking, limited mouth opening, jaw clicking, ear congestion, and nocturnal. It's like code. It's like when a husband and wife or parents talk. The patient comes into me, and she talks in code. So she comes into me complaining about her jaw locking, and she can't open, and she's got clicking in her ear, but she's really saying to me, Doc, I've got an airway problem. I can't stay awake during the day. I'm getting C's in school. Help me. I'm suffocating. I'm dying. But the code is, I've got a jaw problems. That's not why she's coming into me. She comes into me for the pain complaints. What she's really coming into me is for me to save her life and transform her life. Now it gets worse. These are her tonsils. This is her head posture. You can't make this up. You cannot make this up. She ended up being referred. She ended up being referred for sleep study. She had obstructive sleep apnea. She was referred to remove her tonsils. We put her in appliance, and I think she ended up on CPAP, and we're ready for her to lose some weight. But this is a dramatic, dramatic case. There's another patient. She comes in with clicking bilaterally in her joints, jaw clicking while eating, bilateral jaw pain, migraine headache, bad back for many years. I look at her, and if I look at her bite and I look at it closely and I look at, she's actually, her mandible is off to the left. It may be hard to see here because she's not in front of us, but we understand that she's been clicking. We put her in appliance, and this is what her bite turns into being. What you're going to see in dentistry over the next years is that it hierarchically, this is a case where we're just taking care of her. And by the way, if I go back, we got rid of her bad back. Her bad back ache. She didn't have another bad back. She didn't have another migraine headache. She had no more jaw pain. She had no clicking. And that's a result of us putting her in a position. And maybe she felt better because we were opening up her airway. You know, if you look at the before picture, and this again is our cone beam, this is the type of shot that we get sagittally. This is our submental vertex. And this is the before on the top, and this is after on the bottom. So if you call it a concentric, you can call it Gelb 4-7. But basically, if we're not looking at the condyles, and believe me, the condyles are not the be-all and the end-all. I'm the first one that realizes that. But we got rid of the clicking, and with that, the bad back, and with that, the headaches. And listen, I can't say this is a placebo. So this is what we're left with. Her dad's a restorative dentist. He's taken Pankey, he's taken Dawson, and he's restoring the case. And we can look at this view three-dimensionally now, and we can see the compression. Another point here. Ask the question, do you snore? This guy came in, right shoulder pain, jaw pain, bruxism, referred by a chiropractor, significant family history. Father died at age 47 of a heart attack. I said, holy cow, I'm supposed to be an expert in sleep. The guy's father died at age 47 of a heart attack. I'm talking to him a little more. Upon further interview, he reveals that he snores and he has excessive daytime sleepiness. Well, I say to myself, let me look at my cone beam. I look at the cone beam. I go, holy cow. This guy's got a diminished airway. I better do a sleep study. I do a sleep study. Comes out he's got an HI of 32.87. Now, for those of you, we haven't gone into apnea-hypopnea index, but basically when we talk about sleep, sleep could be mouth breathing, sleep could be snoring. There's things called partial obstructions or hypopneas, and there are things called apneas. And then if you add up the number of apneas per hour and you add up the number of hypopneas per hour, you get an index of apneas and hypopneas. That's the number of times that you stop breathing. The guy was at 32.7. He came to me, actually this is a female, but his scores was roughly the same thing. He came to me for jaw pain. Now here's another woman, and we're going to wrap up in a little bit. This woman came to me and she said, I didn't even remember, but she came to me and she said, you saved my life. I said, what are you talking about? She comes into me with pain in the lower right quadrant, numbness in the right mental nerve, swollen salivary gland. I look at her, she's got a large tongue, high tongue level, Mallampati class 3, issue of sleep study, she's got sleep apnea. This is what she looks like. She came into me because she had pain in tooth number 30. She had a crack in this tooth, and the dentist said, I think you should go see Gelb. I want to do a root canal. Look at her neck. So she said, you know what? You were the one. You're a dentist. You're the one who saved my life. That is transforming someone's life. And she came to me and she thanked me. Don't forget, she came in for a cracked tooth and numbness. By the way, all the pain went away in the tooth and all the numbness went away around the mental nerve. This is what we see. This is our typical 4 bicuspid case. This is kind of what we see in New York. And now, I used to think TMJ now, what I think about in these cases now, airway. And what's going to be the performance? What am I doing for his performance? What's his attentiveness going to be? What's his concentration going to be? What's his mood going to be like? Is he going to have panic attacks? What have I done? Have I looked at his airway? Have I examined his airway? Have I looked at his TM joints? And so I'm hoping that we can reverse the trend. Maybe we can take some questions after this, but these are 8 things that every mother needs to know about restorative breathing. Breastfeed if you can for at least 2 months. Make sure, like the American Indians do, that your child is a nasal breather. If you're a mouth breather, first of all, that's a sign that there's a problem. Make sure that you test for allergies, food allergies, wheat, dairy, environmental allergies. Avoid thumb sucking and pacifiers. Don't let your kids, look, it's easy to say, I've got 2 kids, but try to not have them do digit sucking. Find an orthodontist from the American Academy of Physiological Medicine and Dentistry. Find an orthodontist that does expansive type orthodontics. Look at frenums. Get a frenectomy. If you look at BioLays, they have a package now where the dentist can address frenums. You can get a cone beam CAT scan. You've got to start looking at the entire airway. Don't extract permanent teeth except thirds. Avoid retractive headgear. You can use reverse headgear, but don't use retractive headgear. Get the tonsils and adenoids out early. Get your child a sleep study if they have sleep-disordered breathing. If your child has bedwetting, I was a bedwetter. All my bedwetting stopped when I got my tonsils out. Bedwetting is a parasomnia. Night terrors will go away. These are parasomnias. These are disorders that we can help with if we expand maxillas and get out the tonsils and adenoids. You got to do early intervention, and it's a team effort. Jeff, do you want me to keep going?
Yeah, Dr. Gelb, we're kind of getting toward the end of the hour. If you'd like, we can record questions that are coming in and then just kind of let you go ahead and keep speaking.
I can take some questions if you want. It's totally up to you guys.
Well, sure. And perhaps one of the things, everyone keep an eye out on Dentalcompare. There's so much great information here, and Dr. Gelb is just really scratching the surface for you. It may be that we can do a second part to this series so that we can kind of expand further and show you some of these amazing cases. One question that's coming up is, Dr. Gelb, is that you're showing some pretty young patients, and on your current slide where it says early intervention 0 to 5.
Yeah.
How young are you doing? Are you talking about doing actual CT scans on patients that are in that age range? How young can you go with that?
Well, here's what it is. When I speak to the ENT, the problem with taking out tonsils and adenoids has always been they had to have like 7 tonsil infections in a year. But right now, if the parent has a report that the kid has trouble breathing, so if the parent reports even one apneic event or the kid is snoring, in many cases, you don't even need a sleep study. If you go into an ENT, and it's got to be a pediatric ENT that is trained in sleep, and I really believe that you've got to find the right person, the right ENT, but they will take out those tonsils and adenoids. So, usually it's in their bailiwick, but if you see a palate that is narrow and constricted, I would say let the ENT go in and take the tonsils and adenoids. But if you look at the study that was done with Guillemot, 30 out of 32 kids needed both tonsils and adenoids taken out and palatal expansion. So I think this is such a great field for the pediatric dentist, for the orthodontist that's willing to intervene early and that gets it. But typically we're not taking cone beams on these young kids. On the young kids we're not. But believe me, most of these kids have not. We have such a huge adult population that we're treating that's undiagnosed that there's plenty of adults out there. There's plenty of adolescents out there that have this problem. So I'm just saying I'm making a plea to everyone because I'm tired of seeing these cases. I'd like to try to put myself out of business if I could. I'm tired of seeing these kids that have been constricted and had teeth taken out and things like that. So I'm really advocating for you guys that have children, grandchildren, that we at least make the attempt to transform their lives early. The other people is where we're really doing the cone beam CAT scans. And if you look at a guy like this, look, most of us, my neck size is 17. It used to be 15 and a half. I was 192, tennis player in college. I'm now 215, on a good day. So, we're all putting on weight. Our necks are getting bigger. And most of us snore. Let's be honest. Most of us have at least mild to moderate apnea or we snore. So this is a problem that is in every dental practice in the United States. I guarantee every dental practice in the United States has at least 40% of the people in their practice who snore. And probably at least conservatively 10% and up to 20% of the practice has sleep apnea. So it's an epidemic. It's in epidemic proportions, especially in those states where the obesity rate is 25% and above. Right.
And maybe in a part 2 we can get into some of the treatment modalities and equipment you use, such as, there's a question about appliances that are coming in, a question on how do you incorporate lasers for some of the soft tissue stuff. But kind of sticking with the diagnosis kind of side of things, you keep bringing up that particular cone beam, the Newton. That's a lay-down machine, if I'm not correct. Do you find that there's a difference between this for what you need it for sleep apnea diagnosis that comes up when you consider a stand-up model or version of that versus a lay-down model?
Well, you know, what I find is that in most dental practices in the United States, the footprint, the layout of the practice, there used to be a panoramic there, you know, in a lot of cases. And so I actually have a stand-up unit in my office because I didn't want to the real estate's so expensive in Manhattan that I didn't dedicate a supine unit. So I have a stand-up unit. I've got a VG, which is, you know, it's a great unit. I get these great shots with that unit. And Schwab found that if you have a diminished airway upright, there is a significant difference between apneics and non-apneics. So, you know, if I'm seeing a diminished airway when they're upright, you can imagine how bad it would be if they were lying down. It would be much worse. Yeah.
Right. Right. Well, Dr. Gelb, thank you so much again for this. I mean, this is, as you said, sort of the new standard of care to kind of think of this as airway-centric therapy. So we really appreciate your thoughts and your time on this. And again, everyone else, maybe keep an eye. We'll see if we can tempt Dr. Gelb to come back and do you know, kind of continue on with all these. So, Dr. Gelb, again, thank you so much.
Thanks a lot, Jeff. I appreciate it.